I want you to imagine your body for a second, but not, as flesh and bone. Think of it more like a highly complex microscopic power grid.
Right, a massive network.
Exactly. Just picture it. Trillions of individual homes and factories. And those are your cells.
Yeah.
And every single one of those microscopic structures requires a really steady, precise, uninterrupted delivery of fuel just to keep the lights on,
Right, just baseline functioning.
to keep the machinery running.
Right.
And that ultimate biological fuel is glucose.
The purest form of energy.
Yeah. And the delivery system your body uses to get that fuel out of the food you eat and into those trillions of cells. I mean, it is an absolute marvel of biological engineering.
It really is.
But what happens when that grid's delivery system malfunctions? Like, what happens when the fuel is surging right there in the pipelines, but the homes are suddenly locked out? They just go dark one by one.
Well, it's a terrifying scenario for a cellular organism.
Right.
Because if the cells cannot access the fuel that's flowing right past them, the entire organism begins to collapse.
Which is crazy to think about.
It is. And that invisible internal collapse is the exact reality of a disease that affects, tens of millions of people in the United States alone.
Which brings us to today. Welcome to your personal deep dive. Today, our mission is to completely decode the mechanics of diabetes.
And we really want to get into the weeds here.
Yeah, we're not going to just run down a list of surface-level symptoms that you've probably heard 1,000 times on medical commercials.
Right, the usual stuff.
We want to actually look under the hood of the human body. We're going to figure out how this works. We want to understand the actual microscopic disease process.
The real pathophysiology.
Exactly. How blood sugar is managed in a perfectly healthy system, how that delicate machinery fails in both type 1 and type 2 diabetes, and then precisely how blockbuster medications like metformin and those newer GLP-1 agonists actually hack your biology to fix it.
Because to really understand the disease, and certainly to understand the chemical brilliance of how these medications work, you first have to understand the healthy system.
The baseline.
Right. Before we analyze the breakdown, we have to establish the beautiful, delicate balance of how your healthy body regulates energy.
Because it's impressive.
It puts our best human-engineered power grids to shame, honestly.
So let's start at the very beginning of the pipeline. You sit down, you eat a massive plate of pasta.
Sounds good.
Right. And your digestive system immediately goes to work breaking down those complex carbohydrates.
Breaking them all down.
Because ultimately, the body is trying to reduce that entire meal into glucose.
Right, the purest cellular energy.
And then that glucose gets absorbed through your intestines and dumped straight into your bloodstream.
Right.
But the glucose can't just, walk into a muscle cell or a brain cell on its own to be used for energy.
No, it can. The glucose is entirely trapped at that point.
It's just floating there.
Exactly. It's freely circulating in the blood, bumping up against the outside of your muscle and fat cells, but the cell walls are impermeable to it.
Like locked doors.
They're essentially locked doors. And this is where the star of the show comes in.
Insulin?
Insulin. It is the mandatory transporter. Out of all the complex chemistry in your body, insulin is the only hormone that can facilitate the movement of glucose from the blood into the interior of the cell.
So it's the master key.
It is the master key.
So if insulin is the key, where is it kept? Because I know the pancreas is involved, but I always picture the pancreas as this organ just vaguely sitting somewhere near the stomach.
Yeah, a lot of people do.
How does it actually produce this master key?
Well, the pancreas is a dual-purpose organ. It's tucked right behind your stomach. And mostly it's dedicated to producing digestive enzymes.
Okay.
But scattered throughout the pancreas are these tiny, incredibly specialized clusters of endocrine tissue. And they have a rather poetic name, the islets of Langerhans.
The islets of Langerhans. I mean, that sounds like a location in a fantasy novel.
It really does. And they really are like isolated little islands of tissue.
Right.
And within these islands, there are highly specialized manufacturers called beta cells, or often just referred to as B cells.
Okay, so the beta cells are the key makers.
Exactly. They have one sole purpose in life: to continuously monitor the exact concentration of glucose in your blood and manufacture and release insulin accordingly.
And they have a really demanding job, right? Because the body is desperately trying to maintain a very narrow, vital, normal glucose range.
Extremely narrow.
We're talking about keeping blood sugar between 70 and 120 milligrams per deciliter.
Right.
That sounds like an incredibly tight window for a system that constantly experiences massive influxes of sugar every time we eat.
It's a huge challenge.
So how do these little beta cells possibly manage that tightrope walk?
They achieve it through this brilliant two-tiered release system. You can think of it as a constant background hum combined with highly targeted, massive surges.
Okay, a background hum.
Right, the first tier is what endocrinologists call the basal rate.
So what does that basal rate actually look like on a cellular level?
Well, even when you're sleeping or fasting between meals, your body still needs energy. Your brain is dreaming, your heart is beating, your lungs are expanding.
Right, you're not turned off.
Exactly. So to fuel that baseline activity, your liver is actually slowly releasing a trickle of stored glucose into the blood.
Oh, I see.
And to match that, your healthy beta cells are continuously secreting a small, steady, microscopic amount of insulin.
Just a constant drip.
Right. This basal rate ensures there's always just enough of those master keys floating around to unlock the doors and keep the baseline energy flowing into the cells.
Keeping the blood sugar stable.
Exactly.
Okay, tier 1 makes perfect sense for when I'm just sitting here reading a book.
Yeah.
But let's go back to that massive plate of pasta.
The big meal.
Right, I finished the meal, and suddenly there is a literal flood of glucose rushing from my intestines into my bloodstream.
A huge spike.
That gentle background hum of insulin isn't going to cut it, right?
Not even close.
Yeah.
That massive influx triggers the second tier,
Which is?
the bolus release. So the beta cells are equipped with highly sensitive glucose receptors.
Yeah.
And the second they sense that massive wave of sugar hitting the bloodstream, they instantly react. They release a massive surge, a bolus of prepackaged insulin directly into the blood.
So they essentially match the intensity of the...
Perfectly. It is absolute chemical choreography.
Yeah.
The pancreas releases an amount of insulin that precisely mirrors the carbohydrate load you just consumed.
Wow.
Yeah, and this flood of keys ensures that the sudden wave of sugar is rapidly transported out of the blood and into the cells, preventing your blood glucose levels from spiking dangerously above that 120 mark.
I really love thinking about this mechanically.
It helps, right?
It does. So insulin is essentially like a physical key that unlocks the cell door to let the glucose in.
Right.
And the beta cells in the pancreas are like a highly advanced, smart thermostat.
Oh, that's a good way to put it.
It's constantly reading the room's temperature, the blood sugar, and adjusting the air conditioning, the insulin.
Exactly.
If it's a mild day, it just runs a low continuous fan, which is our basal rate.
Yeah.
But if you suddenly turn on an oven and bake that pasta, creating a heat wave of glucose, the thermostat instantly kicks on a massive blast of cold air to handle it, which is our bolus release.
That is the phenomenal analogy for how the system cools down a spike. But the body doesn't just have an air conditioner.
Right.
To be a true thermostat, it has to have a heating system too. And this introduces a critical concept around the counter-regulatory hormones.
Okay, so we have insulin to lower blood sugar, just one hormone.
Root to one?
But when you look at the biology of how the body raises blood sugar, there are actually 4 completely different hormones dedicated to working against insulin.
For them, yeah.
We've got glucagon, epinephrine, growth hormone, and cortisol.
Correct.
Why the massive imbalance? Why does human biology dedicate 4 massive chemical systems to raise blood sugar and only one single hormone to lower it?
It seems skewed, right?
Yes. Is there some evolutionary reason that makes low blood sugar infinitely more terrifying to our bodies?
You've hit on a fundamental truth of human physiology there.
Yes.
Okay. Hypoglycemia, blood sugar that drops too low, is an immediate, catastrophic, life-threatening crisis.
Immediate.
Right. Mild hyperglycemia, blood sugar that is too high, is a slow poison.
Okay.
High sugar causes immense damage over decades, but low blood sugar can kill you in minutes.
That is so counterintuitive for a lot of us, I think,
Yeah.
because all we ever hear about in the media is the danger of high blood sugar with diabetes.
Right, because it's so common.
So why is low blood sugar so immediately lethal?
Because of your brain.
Yeah.
Your brain is an absolute energy hog.
Really?
Oh yeah, it consumes about 20% of your body's entire energy supply.
Wow.
But it has almost zero capacity to store its own energy. It relies exclusively on a continuous, second-by-second delivery of glucose from the bloodstream.
So it's constantly feeding.
It has to. If your blood glucose drops below that 70 mark and keeps falling, your brain cells literally begin to suffocate. Yeah, without that energy, all cognitive processes halt.
Yeah.
You experience profound confusion, your vision blurs, you lose consciousness, you seize, and ultimately, you experience rapid systemic shutdown.
Wow. So those 4 counter-regulatory hormones, the glucagon, epinephrine, growth hormone, cortisol, growth, they aren't just adjusting the thermostat.
No.
They are the emergency backup generators kicking in to save your brain.
They are the ultimate fail-safe. Let's say you have an incredibly stressful day. You skip breakfast, you skip lunch, and you haven't eaten a single calorie in 14 hours.
Right. Terrible day.
Right. Your blood sugar is drifting dangerously low. So first, the pancreas releases glucagon, which travels straight to the liver and screams at it to dump its emergency stores of glucose into the blood.
The liver just dumps it all.
Exactly. And if that's not enough, epinephrine, which is adrenaline, surges, forcing even more sugar out of storage.
Okay.
Then cortisol and growth hormone kick in, actively preventing the muscle and fat cells from absorbing any of the remaining glucose, effectively keeping it locked in the bloodstream.
Wait, so they are purposefully starving the muscle cells just to ensure the brain gets the last remaining drops of fuel?
Precisely the goal.
Okay.
They step in to artificially raise the blood sugar back into that safe 70 to 120 range.
Wow.
It is an evolutionary masterpiece of survival.
It really is. Okay, so we have a crystal clear picture of the healthy power grid.
The baseline.
Right. The pancreas is the smart thermostat. Insulin is the master key. Basal and bolus rates keep the flow perfectly steady. And those 4 counter-regulatory hormones are the emergency backup generators keeping the brain alive.
Beautifully balanced.
It's an elegant system, but this whole deep dive is about what happens when it breaks.
Right.
So let's look at the first major system failure, type 1 diabetes.
Yeah, the breakdown.
And this is a situation where the body's own elite defense system basically turns around and bombs its own power plant, right?
That is the tragic reality of type 1 diabetes. It is a disease defined by absolute destruction. Historically, you might have heard it called juvenile onset or insulin-dependent diabetes. The defining characteristic is the autoimmune annihilation of those crucial, beautiful beta cells we just discussed.
Now, you mentioned juvenile onset, and I'll admit, I always pictured type 1 as strictly something you were born with or something diagnosed when you were a toddler.
A lot of people think that.
But looking at the clinical data, while about 40% of cases are diagnosed before age 20, the onset can actually occur all the way up to age 30.
Yes.
How does a 25-year-old suddenly develop this?
Well, the mechanism is identical regardless of age, and it begins with genetics. Specifically, researchers point to certain genetic markers called human leukocyte antigens.
Okay.
You can think of an HLA as a cellular ID badge. Every cell in your body has an HLA badge that tells your immune system, hey, I belong here, I am part of the body, don't attack me.
So the immune system patrols the body, just checking these ID badges.
Yes. But in type 1 diabetes, there is a genetic flaw. People who develop type 1 typically inherit specific, flawed ID badges.
Like fake IDs almost.
Sort of. They're specifically identified as HLA-DR3 and HLA-DR4. But having the genetic predisposition doesn't mean you automatically get the disease.
Oh, it doesn't?
No. The gun is loaded, but something has to pull the trigger.
So what pulls the trigger? What causes the immune system to suddenly stop recognizing its own tissue?
Usually it is environmental exposure.
Like what?
It could be a common viral infection or perhaps exposure to a specific chemical toxin. And when a person carrying those flawed HLA-DR3 or DR4 ID badges is exposed to this trigger, their immune system naturally mounts a massive defense to fight off the virus.
Right, doing its job.
But in the chaos of that immune response, there is a catastrophic case of mistaken identity.
A molecular mix-up.
A phenomenon called molecular mimicry. The immune system's T cells, which are the heavily armed elite assassins of your immune system, designed to hunt down and kill infected cells, suddenly misidentify the beta cells in the pancreas.
They just get it wrong.
Yeah, they look at the beta cell's ID badge, get confused by the genetic flaw combined with the viral signature, and classify the beta cell as a deadly foreign invader.
So these elite assassin T cells just launch a full-scale, unprovoked assault on the islets of Langerhans.
A relentless assault. They systematically hunt down and execute the beta cells.
Wow.
And the scary part is the patient feels completely fine for months, even years, while this invisible war is raging.
Because they have backups.
Right. But eventually, the destruction crosses a critical threshold. The factory is burned to the ground.
And then what?
The consequence of this autoimmune destruction is absolute. The patient eventually produces little to absolutely zero endogenous insulin.
The keymaker has been completely eliminated.
And without the keymaker, everything we just discussed about the power grid collapses.
So without any insulin keys, the glucose from all the food you eat just builds up and builds up in the bloodstream.
It has nowhere else to go.
The blood becomes completely saturated with sugar. But this brings up a seemingly bizarre, almost impossible contradiction.
Okay, what's that?
Well, if there is a massive buildup of pure glucose, pure cellular energy in the bloodstream, why does a newly developing type 1 diabetic experience sudden, dramatic, terrifying weight loss? I
Ah.
mean, I would think that having all that extra energy floating around in the blood would make them gain weight rapidly.
It is one of the most brilliant questions in human biology,
Mhm.
honestly. And the answer cuts to the absolute core of how life functions on a cellular level.
Right.
You have to think back to our locked door analogy. Yes, the bloodstream is practically a raging river of pure glucose, but because the beta cells are dead, there's zero insulin,
Zero keys.
zero keys, so the doors are bolted shut.
And they can't be forced open?
They cannot be forced open. None of that massive river of glucose can cross the cell membrane. The cells of the muscle, the fat, the organs, they are completely locked out of the energy grid.
So they are swimming in an ocean of food, but they are starving to death.
Literally starving to death.
That's insane.
And what does a biological organism do when it is starving? It panics.
It tries to survive.
Right. The cells send out chemical emergency signals screaming, "We have no fuel, we are dying."
Yeah.
The brain registers this starvation and takes drastic measures to survive. It activates enzymes that begin to rapidly cannibalize the body's own tissues.
Wow.
It aggressively breaks down stored body fat and begins tearing apart muscle protein, converting them into alternative fuels just to keep the vital organs from shutting down.
So that aggressive burning of fat and muscle tissue is what causes the profound rapid weight loss.
Exactly. The body is consuming itself from the inside out because it believes it is in a famine, all while the blood is literally thick with unused sugar.
That is tragic, but mechanically it is fascinating.
It really is.
And the cellular starvation directly drives what the medical field refers to as the classic 3 Ps of type 1 diabetes symptoms.
Right, the cardinal signs.
Let's break these down because understanding the underlying mechanism makes these symptoms suddenly make perfect sense.
Yeah, let's do it.
The first P is polyphagia.
Right, polyphagia translates to extreme insatiable hunger.
Because the cells are starving.
As we just discussed, the cells are malnourished. They are sending starvation signals to the brain. So the brain responds by ramping up the appetite to extreme levels.
It's just screaming, eat.
Exactly. The patient feels a ravenous hunger. They eat constantly, but because there's no insulin, none of that ingested food reaches the cells. The starvation signal never turns off.
So they eat massive amounts of food, but still rapidly lose weight.
It's heartbreaking.
Okay, the second P is polyuria, extreme frequent urination. Now, how does a lack of insulin in the pancreas cause you to urinate constantly?
To understand polyuria, we have to look at the kidneys. And we have to talk about a fundamental principle of physics,
Physics.
osmosis.
Oh, great.
Your kidneys are the body's filtration system. All day long, your blood passes through millions of tiny microscopic filters in the kidneys called glomeruli.
Okay.
Normally, the kidneys filter out waste and reabsorb all the valuable things like water and glucose back into the blood.
Keep the good, toss the bad.
Right. But in a type 1 diabetic, the blood is overloaded with glucose.
Saturated.
The concentration is staggeringly high, and glucose is a heavy, osmotically active molecule.
What does that mean practically?
Well, when the blood filters through the kidneys, the tiny transport proteins whose job it is to pull glucose back into the blood get completely overwhelmed by the sheer volume of sugar. They literally max out their
We
capacity.
just can't keep up.
Exactly. So the excess glucose spills over into the urine.
It leaks out of the filtration system.
Yes. And because glucose is heavy and osmotically active, it acts like a powerful sponge.
Okay.
Wherever glucose goes, it forcefully drags water along with it to try and dilute itself.
Osmosis.
Right. So as this heavy sugar spills into the urine, it exerts an immense osmotic pull, dragging massive amounts of the body's water out of the tissues and into the bladder.
Wait, the sugar is literally pulling the hydration right out of their body.
It forces the kidneys to flush out gallons of fluid just to carry the sugar away. This results in extreme, relentless urination. That is polyuria.
Which logically and immediately triggers the third P, polydipsia, extreme thirst.
Exactly. The severe dehydration caused by that osmotic diuresis, the polyuria leaves the body's tissues completely parched.
Because they just peed out all their water.
Right. The blood volume actually drops because so much water is being lost. So the brain's thirst centers detect this dangerous dehydration and trigger extreme, unquenchable thirst
Trying to replace the water.
to try and force the patient to replace the massive amounts of water being flushed down the toilet.
Wow.
So you have a patient who is starving, losing weight rapidly, urinating constantly, and drinking gallons of water every day. That is the classic acute presentation of a total system failure in type 1 diabetes.
Okay, that is type 1. It is a disease of absolute absence. The insulin factory is burned to the ground.
Right.
But now we need to shift gears and look at the other side of the coin. Let's look at the second major system failure, the pathophysiology of type 2 diabetes.
Very different mechanism.
Because the biology here is completely different. This isn't a disease of absence, is it?
Not at all. Type 2 diabetes is fundamentally a disease of profound inefficiency and resistance.
Inefficiency!
Yeah, the crucial distinction that everyone needs to grasp is that unlike a type 1 patient, a person developing type 2 diabetes does still produce their own endogenous insulin.
Oh, they do?
Yes, their beta cells were never attacked by the immune system. The factory is still open and operating.
So if they have the keys, why are they locked out of the homes?
Because the system fails at the cellular level.
How so?
The insulin being produced is either insufficient for the sheer volume of the body's needs, or it's not being utilized properly by the cells, or, and this is usually the case, a devastating combination of both.
A double whammy.
Right. In clinical terms, we look at 4 distinct metabolic abnormalities that drive this disease.
Let's walk through these 4 abnormalities because it paints a picture of a really complex, multi-layered breakdown.
It does.
The primary driver, the first abnormality, is insulin resistance. What does that actually mean on a molecular level? What is actively resisting the insulin?
The body's peripheral tissues,
Mm-hmm.
specifically the muscle cells, the fat cells, and the liver cells.
Okay.
The insulin is perfectly fine. The keys are floating in the bloodstream. But the microscopic receptors on the outside of the cell door's fat, the locks have changed.
Why do the locks change? Do they just degrade over time?
It is largely driven by excess visceral body fat and chronic inflammation.
Ah, okay.
When muscle and organ cells are bathed in excess fatty acids and inflammatory chemicals, the internal signaling pathway of the insulin receptor gets jammed.
Jammed up.
Imagine the insulin receptor is a nightclub bouncer.
Okay, I like this.
The insulin hands him a perfectly valid VIP pass to let the glucose inside. But the bouncer is distracted by a blaring fire alarm and a chaotic crowd, which represents the fatty acids and inflammation.
So he just ignores the pass.
He ignores the VIP pass. He refuses to open the door. The tissues simply stop responding to the insulin that is present.
So the lock is jammed. Which leads us to the second abnormality, decreased insulin production. Now, I'm genuinely confused by this one.
Okay, why?
Well, if my muscle cells are resisting the insulin and the blood sugar is staying high, why wouldn't my perfectly healthy pancreas just crank out a massive tsunami of insulin to kick the doors down? Why does production go down?
Well, the thing is, it actually does crank out a tsunami at first.
Oh, it does?
Yeah. In the early stages of insulin resistance, the beta cells sense that the blood sugar isn't dropping. So they do exactly what you suggested. They work double, triple, quadruple overtime.
They go into overdrive?
They pump out massive, unnatural amounts of insulin, essentially trying to shout over the noise and force those stubborn locks open through sheer volume.
They try to brute force the system.
And for a few years, it might actually work.
Really?
Yeah, the blood sugar stays relatively normal. But biological tissue has its limits.
Of course.
Imagine running a car engine at the red line constantly. Eventually, the engine parts melt.
Right, it burns out.
The beta cells become physically exhausted from the constant, relentless overwork. They experience cellular stress, and they begin to die off or simply lose their functional capacity.
The factory workers literally burn out and collapse.
You do.
Yeah.
And this slow decline introduces a very critical, dangerous gray area known as impaired glucose tolerance, or IGT.
IGT, okay.
This is the phase where the beta cells are getting tired. They can still make some insulin, but they can't make enough to overcome the massive resistance.
They're losing the battle.
Right, so the blood glucose levels start to elevate above that normal 120 mark, but they aren't quite astronomically high enough yet to trigger a full-blown type 2 diabetes diagnosis.
So it's like a warning sign.
It is the check engine light flashing violently on the dashboard.
Okay, so we have tissues ignoring the keys, and the key maker is burning out from exhaustion.
Right.
The third abnormality has to do with the liver inappropriate hepatic glucose production. How does the liver get involved in this mess?
Well, remember our counter-regulatory hormones and the emergency backup system.
Ones that save the brain from starving.
Exactly. In a healthy person, the liver stores glucose and only releases it when you are starving to save the brain.
Yeah.
But in type 2 diabetes, the liver becomes completely deaf to the body's signals.
Why?
Because of the systemic insulin resistance, the liver's internal sensors are essentially broken. It thinks the body is starving, even when the blood is overflowing with sugar.
So it starts producing more.
It goes completely rogue. Through a process called gluconeogenesis, the liver starts haphazardly manufacturing and dumping huge amounts of extra glucose into the bloodstream at completely the wrong time,
Just flooding an already flooded system.
further elevating the blood sugar levels for absolutely no logical reason. It is actively pouring gasoline on a fire.
Wow. And the fourth abnormality is something called adipokine alteration. And this brings us back to body fat. I
Right.
think most people view body fat as just inert, inactive storage tissue, like a backpack of extra calories.
That is a massive misconception.
Yeah.
Adipose tissue, especially the visceral fat that accumulates around the abdominal organs, is a highly active endocrine organ.
It does stuff actively.
It constantly produces and secretes hormones and inflammatory cytokines, collectively called adipokines.
Okay.
In a state of developing type 2 diabetes, the biology of this fat tissue alters. It stops producing healthy adipokines that aid metabolism, and instead pumps out toxic adipokines that actively destroy the body's sensitivity to insulin.
Wait, so it's actively manufacturing the inflammation that distracts the bouncer at the cell door?
Precisely. The fat itself is sustaining and worsening the disease.
That is wild. Let me try to pull all four of these abnormalities together into a cohesive picture.
Let's hear it.
If type 1 diabetes is a factory where the key maker vanished overnight,
Right.
type 2 diabetes is a massive industrial breakdown. The locks on the cell doors have been rusted shut by toxic fat hormones.
Yeah.
The key maker is collapsing from a heart attack after working triple overtime trying to make enough keys to force those rusted doors open.
Exactly.
And meanwhile, the warehouse manager, the liver, has lost his mind and keeps randomly dumping extra inventory onto the factory floor, making the mess exponentially worse.
That captures the multifaceted compounding chaos of type 2 perfectly.
Yeah.
Every organ system is feeling the others.
It's just a cascade of failures.
And what makes type 2 so incredibly insidious
Mhm.
is how it presents to the patient.
Right.
We talked about the dramatic, violent symptoms of type 1, the rapid starvation, the gallons of urine. Type 2 is a slow, silent killer.
The onset is completely different. Like, the medical literature notes symptoms like generalized fatigue, recurrent infections, prolonged wound chilling, and visual changes.
Very subtle.
But why infections? Why does having rusted cellular locks suddenly make you prone to getting sick?
It comes back to the environment of the bloodstream. We established that the blood is thick with excess glucose.
Right.
Well, human cells aren't the only organisms that love glucose. Pathogens, specifically bacteria and yeast, thrive on sugar.
Oh, of course.
A bloodstream and urinary tract with elevated glucose is essentially an all-you-can-eat buffet for microscopic invaders.
So they just multiply.
This leads to chronic, recurrent infections, particularly urinary tract infections and yeast infections.
They're literally feeding the bacteria.
Exactly.
The prolonged wound healing.
That is the beginning of the vascular damage.
Yeah.
That thick, syrupy blood is incredibly abrasive. Over years, it damages the delicate inner linings of the microscopic blood vessels, the capillaries. This reduces circulation.
So blood can't get where it needs to go.
Right. If you get a minor cut on your foot, your body needs a robust blood supply to deliver white blood cells and healing factors to close the wound.
Yeah.
But if the vessels are damaged by sugar, the healing factors can't reach the site. A simple paper cut can remain open and vulnerable for weeks or months.
This slow, hidden, creeping failure is why type 2 is such a massive societal crisis.
Yeah.
It isn't a sudden emergency room visit. It's a decade of invisible damage.
It is a profound crisis. Because the symptoms are so vague, just feeling a bit tired or needing new glasses, because the sugar actually changes the shape of the eye's lens.
Wait, it changes the shape of the lens.
It does. The glucose pulls fluid into the lens, altering its shape and causing blurry vision.
That's crazy.
And because these symptoms are so easy to ignore, millions of people walk around for years, completely undiagnosed.
Just living their lives.
The disease is quietly shredding their blood vessels and exhausting their pancreas, and they have no idea until irreversible, catastrophic complications arise.
And the cost of that has got to be enormous.
The financial toll of managing this chronic, late-stage damage costs the U.S. healthcare system hundreds of billions of dollars annually.
Hundreds of billions.
It's staggering.
Before we move on to how medical science actually tries to fix this broken machinery, I noticed a term in the literature that seems out of place: secondary diabetes.
Ah, yes.
If type 1 is autoimmune and type 2 is metabolic resistance, what is secondary diabetes?
Secondary diabetes is a crucial clinical distinction. This occurs when an external artificial factor forces the body into a diabetic state.
So it's induced by something else.
Right. The pathology isn't originating from a broken immune system or poor diet. It is a side effect of something else entirely. And the absolute classic example is the medical use of corticosteroid medications.
Like prednisone.
Exactly. If a patient has severe asthma or an autoimmune disease like rheumatoid arthritis, they are often prescribed high-dose, long-term steroids to suppress inflammation.
Which works for the inflammation.
It does, but steroids are chemically similar to cortisol, one of our counter-regulatory emergency hormones.
And those backup generators.
Yes. So giving a patient high doses of steroids artificially triggers that emergency response.
Oh, wow.
It forces the liver to dump glucose and forces the tissues to become temporarily insulin resistant. It artificially induces diabetes.
That's wild.
It is a stark reminder of how deeply interconnected pharmacology and natural physiology really are.
Which brings us perfectly to the core of this deep dive.
The medications.
Right. We understand exactly how the power grid works. We understand exactly how it collapses. Either the beta cells are assassinated or the tissues rust shut. Now, we introduce the medical interventions.
The fixes.
I want to look at the chemical hacks, the specific pathophysiology of how diabetes medications operate inside the body.
This is where human ingenuity really shines, honestly. Every medication we use is explicitly engineered to target and intercept the specific physiological breakdowns we just detailed.
So let's start with the most direct historical intervention: exogenous insulin therapy.
Taking insulin from outside the body and injecting it.
Obviously, this is non-negotiable, mandatory survival for a type 1 patient. They have 0 keys, so you have to hand them the keys.
Exactly.
But it's also used for advanced type 2 patients when their beta cells finally succumb to exhaustion and die off, right?
Correct. When the factory finally closes in a type 2 patient, you must replace the hormone. But the goal of insulin therapy isn't just to arbitrarily squirt insulin into the fat and hope the blood sugar drops.
It has to be precise.
The medical goal is to perfectly mechanically mimic the healthy pancreatic thermostat we discussed at the very beginning.
So you have to recreate the basal hum and the bolus surge.
Exactly. It requires meticulous chemical choreography.
How do they do that?
A patient will typically inject a highly modified long-acting insulin. It's an insulin molecule that has been chemically altered so it dissolves incredibly slowly over 24 hours. This establishes that steady basal rate background hum.
Just that constant drip.
Right. Then, they use a different vial of rapid-acting insulin. They calculate the exact carbohydrate load of the meal they are about to eat and inject a rapid bolus to mimic the natural surge.
Wow, so they are basically being their own pancreas.
We are attempting to manually drive the automatic systems of the human body.
But for type 2 diabetics, especially in the early to middle stages of the disease, we don't always jump straight to manual override with needles.
No, we don't.
There's an entire world of oral agents, pills. And when you look at the pharmacology of diabetes, there is one drug that stands as the undisputed king of the hill: metformin.
Metformin is one of the most widely prescribed, heavily studied, and profoundly effective drugs in the history of modern medicine.
Really?
It is the gold standard first-line defense for type 2 diabetes. But there is a massive, absolute physiological rule for metformin or any oral diabetic agent to work.
What's the rule?
The patient must still have some of their own endogenous insulin. They must have a functioning, albeit exhausted, pancreas.
Why? Why can't a type 1 diabetic just take a metformin pill instead of an injection?
Because metformin does not contain insulin.
Yeah.
It does not force the pancreas to make more insulin. It is not a key.
So what is it?
Metformin is a systemic modifier. It works by making the existing broken machinery run more efficiently. If there are 0 keys in the system, like in type 1 modifying,
Yeah.
the locks won't do anything.
Okay, that makes perfect sense. So I'm a type 2 diabetic. My locks are rusted, my liver is dumping extra sugar, and my pancreas is tired. I swallow a metformin pill.
Right.
What is that chemical actually doing at the cellular level? How does a pill fix a rusted lock?
Metformin is brilliant because it executes a highly coordinated 3-pronged attack against the specific abnormalities of type 2 diabetes.
Okay, let's break down the attack.
The primary battleground is the liver. Metformin enters the liver cells and actually alters the function of their mitochondria, the powerhouses of the cell.
Okay.
By mildly inhibiting the mitochondrial energy production, it changes the cellular energy balance. This directly signals the liver to shut down gluconeogenesis.
Wait, it flips the switch. It tells the warehouse manager to immediately stop manufacturing and dumping that inappropriate excess sugar into the blood. That fixes abnormality number 3.
Exactly. It cuts off the rogue supply.
That's brilliant.
And the second prong of the attack occurs at the peripheral tissues, the muscle and fat cells. Metformin activates an internal cellular enzyme called AMPK.
AMPK.
You can think of AMPK as a master metabolic switch.
Mm.
When metformin flips this switch, it forces the cell to bring more glucose transporters to its surface. It physically alters the structure of the cell door.
Oh, so it acts like a chemical lubricant.
Yeah.
It fixes the rusted locks, restoring the cell sensitivity so that the patient's own struggling endogenous insulin can actually open the doors again.
It directly reverses the insulin resistance. It kicks the distracted bouncer out of the way.
That is so cool.
And the third, slightly less profound but still vital mechanism occurs in the gut.
Okay, the intestines.
When you eat a meal, metformin mildly interferes with the cellular transport systems in the lining of your intestines. It physically slows down and decreases the absorption of glucose from your food into the bloodstream.
So it limits the influx of sugar at the source.
Exactly.
Okay, metformin sounds like absolute science fiction. It shuts down the rogue liver, it lubricates the cellular locks, and it blocks the intestines.
It's a triple threat.
But every drug has a catch. When you fundamentally alter human metabolism, there has to be a reaction. What are the side effects of hacking the system this way?
Every chemical hack has a consequence directly tied to its pathophysiology. With metformin, because it actively alters how the intestines handle glucose, the local environment of the gut gets very confused.
Confused how?
The most common immediate issue is significant gastrointestinal upset. When patients first start the drug, they almost universally experience nausea, abdominal cramping, or severe diarrhea.
Because the sugar that isn't being absorbed is just sitting in the gut fermenting.
Exactly. It creates an osmotic pull in the intestines, drawing in water, which causes diarrhea.
Ah, osmosis again.
Right. So the clinical imperative is that metformin must be taken directly with a large meal to buffer this effect until the body adapts.
Okay, a stomachache is a small price to pay to save your blood vessels.
Most people agree.
But I was looking into clinical protocols for this drug, and there is a very bizarre, highly specific warning.
I know exactly what you're going to say.
It says that if a patient on metformin goes to the hospital for a CT scan, there can be a catastrophic medical interaction. How does a diabetes pill interact with an imaging machine?
It has nothing to do with the radiation of the machine and everything to do with how chemicals are cleared from the body.
Okay.
Metformin is not processed by the liver. It is excreted entirely in its raw form by the kidneys. It asks a lot of the kidneys to filter it out.
It's hard work for them.
Very hard. Now, to get a highly detailed CT scan, doctors inject the patient with an intravenous contrast dye.
Right, the stuff that makes you feel warm.
Yes, it's a heavy, iodine-based fluid that makes the blood vessels light up brilliantly on the scan.
And what happens when that dye reaches the kidneys?
That contrast dye is notoriously toxic and incredibly harsh on the delicate filtration system of the kidneys.
Oh, no.
If you combine the heavy renal workload of clearing metformin with the acute toxic stress of the contrast dye, you create a perfect storm. It can completely overwhelm the renal system, causing a massive acute kidney injury that can plummet the patient into sudden renal failure.
So the chemical clearance pathways literally crash into each other and destroy the filter.
Yes, it is a purely mechanical clash. That is why the unbreakable clinical rule is that metformin must be discontinued roughly 48 hours prior to any procedure involving phlebite contrast dye,
Just to give the kidneys a break.
and held for 48 hours after to ensure the kidneys can handle one stressor at a time.
That is the kind of hidden physiological interaction that is just fascinating.
Medicine is full of them.
Now, metformin has been the king for decades. But recently, there is an entirely new class of drugs that has completely taken over the cultural conversation.
Oh, absolutely dominating it.
They are dominating the headlines, dominating social media. I'm talking about the GLP-1 agonists, drugs like semaglutide.
Right.
People view them almost as magic weight loss injections, but they are fundamentally diabetes medications. How do these fit into the biological picture we've painted?
GLP-1 agonists represent a massive revolutionary leap forward in our understanding of metabolic biology.
Yep.
They operate on an entirely different physiological pathway than metformin.
Okay.
To understand them, we have to understand what GLP-1 is. It stands for glucagon-like peptide 1.
Is that a hormone we already have?
Yes, it is a natural hormone produced by the L cells in your intestines. When you eat, your intestines release GLP-1.
What does it do naturally?
It is an incretin hormone. It signals to the pancreas, hey, food is coming down the pipe, get the insulin ready.
Like an early warning system?
Exactly. The problem is natural GLP-1 is destroyed by enzymes in your blood within about 2 minutes. It is a very fleeting signal.
Just a quick blip.
Right.
So what does the drug do? What does the word agonist mean in this context?
In biology, an agonist is a synthetic molecule that perfectly mimics a natural molecule, fitting into the same cellular receptors to trigger the same action.
Okay.
A GLP-1 agonist is a synthetic clone of your natural gut hormone, but it has been chemically armored so that the enzymes in your blood cannot destroy it.
Oh, wow.
Instead of lasting 2 minutes, a single injection lasts for an entire week.
So you are artificially screaming the food is coming signal at the body 24 hours a day?
Exactly. And the cascading biological effects of that constant signal are profound.
What's the first effect?
First, it forces the pancreas to suppress the release of glucagon. Remember glucagon?
Wow.
The backup generator hormone that tells the liver to raise blood sugar.
Wait, so the drug actively cuts the alarm wire. It stops the body from artificially spiking its own sugar.
Precisely. Second, it goes to the pancreas and actively promotes the survival and growth of the beta cells while stimulating them to release more insulin.
So it helps the key makers directly.
It does. But the third mechanism, the one causing the cultural phenomenon, happens in the stomach and the brain.
The gastric emptying delay.
Yes. GLP-1 powerfully paralyzes the muscles of the stomach. It dramatically slows down gastric emptying. The food you eat sits in your stomach for hours and hours longer than it normally would.
Just sitting there.
Physiologically, for a diabetic, this is brilliant because it drastically slows the absorption of glucose into the blood, completely eliminating those dangerous post-meal blood sugar spikes.
Right, because it's not all hitting the bloodstream at once. But behaviorally, it changes everything.
It really does. Because the stomach is physically distended and full of food for hours, the stretch receptors in the stomach continuously fire signals to the satiety centers in the brain.
Telling the brain, I'm full.
Yes. Furthermore, the synthetic GLP-1 hormone crosses the blood-brain barrier and directly stimulates the neurons that control appetite.
It actually enters the brain.
Yes. So the brain genuinely believes the body has just eaten a massive Thanksgiving dinner all day, every day.
That's wild.
The patient experiences profound, unshakable fullness. The desire to eat simply vanishes.
Which inevitably leads to the rapid, massive weight loss everyone associates with these weekly injections.
Right.
But from a clinical perspective, for a type 2 diabetic, that weight loss isn't just a cosmetic side effect, is it? It's fundamentally attacking the root cause of the disease.
It is arguably the most powerful medicinal effect possible. We established that the core of type 2 diabetes, the insulin resistance, is driven by the toxic hormones secreted by excess visceral fat.
The fat that rusts the locks.
Exactly. The fat is what rusts the cell locks. By causing the patient to rapidly shed dozens of pounds of that metabolically toxic adipose tissue, you are physically stripping away the armor of the disease.
You're just removing the interference.
The patient's natural insulin sensitivity skyrockets. The keys start working smoothly in the locks again simply because the biological static of the fat has been eliminated.
It is truly breathtaking how human engineering can precisely intercept these specific broken pathways.
It's incredible.
We can manually run the thermostat with insulin, we can lubricate the cellular doors with metformin, and we can mimic gut hormones to rewire the brain and melt away the toxic fat with GLP-1s.
It is a golden age of pharmacology, truly.
But as with everything in medicine, we have to look at the dark side of the equation.
The complications.
What happens when these brilliant medications fail? Or what happens to the millions of people who can't afford them or who live for a decade with this disease completely undiagnosed?
It's a grim reality.
We need to look at the systemic ripple effect, the long-term catastrophic complications of letting the power grid run wild.
This is the grim reality of the disease, and it emphasizes why those tight glucose targets are not optional. Diabetes is not a disease of the pancreas.
What is it then?
It is truly a multi-system global disease of the blood vessels. We discussed earlier how the high glucose creates a thick, hyperosmotic, syrupy blood. I use a very specific visceral metaphor for my medical students. I tell them to imagine pumping liquid sandpaper through the delicate pipes of their body 24 hours a day for 20 years.
Liquid sandpaper, that is a horrifying, deeply uncomfortable image.
It is medically accurate. The heavy glucose molecules, physically and chemically, erode the inner endothelial linings of the blood vessels.
They just scrape it away.
Yes. And this happens on two fronts. The macrovascular, which are the large vessels, and the microvascular, which are the microscopic vessels.
Okay, let's start with macro.
The macrovascular damage accelerates atherosclerosis, building up massive plaques in the major arteries. This is why a diabetic patient is at a staggeringly high risk for massive cardiovascular events,
Like heart attacks.
catastrophic heart attacks, and devastating ischemic strokes.
And the microvascular damage.
That is where the disease slowly dismantles the body piece by piece. It shreds the tiny microscopic capillaries that feed the retinas in the eyes, making diabetes the leading cause of new-onset adult blindness. It destroys the millions of microscopic filters in the kidneys, ultimately driving the patient to dialysis.
Just grinding them down.
But perhaps the most insidious, life-altering complication detailed in the pathology of this disease is neuropathy.
Nerve damage. The clinical data suggests this affects between 60 and 70% of all diabetic patients.
A massive majority.
That is terrifying. Let's break down the pathophysiology of neuropathy. How does sugar in the blood physically kill a nerve?
Well, your nerves are living tissues. They require their own dedicated microblood supply, tiny vessels called the vasa nervarum.
Okay.
The liquid sandpaper effect destroys these microscopic feeder vessels. At the same time, the excess glucose physically enters the nerve cells and is converted into a toxic alcohol called sorbitol.
Sorbitol, doesn't that cause swelling?
Exactly. It causes the nerve cell to swell and burst. The nerves essentially suffocate, starve, and explode from the inside out.
That is brutal.
It is.
The clinical breakdown divides this into two main types: sensory neuropathy and autonomic neuropathy. Let's start with sensory. How does a patient experience a suffocating nerve?
Sensory neuropathy primarily affects the peripheral nervous system, particularly the furthest reaches of the circulatory system, the lower extremities, the feet and legs.
Okay.
As the nerves begin to die, they misfire wildly. This initially presents not as numbness, but as severe, agonizing, burning electrical pain.
It's like short-circuiting.
It is a cruel irony. The nerve is dying, but it screams violently on the way out.
A patient walks into a clinic in agonizing pain. I'm assuming a doctor prescribes a painkiller. But the pharmacology of treating nerve pain is uniquely frustrating, isn't it?
It highlights a massive limitation in medicine. Doctors frequently prescribe specific non-opioid analgesics, or drugs originally designed as anticonvulsants or tricyclic antidepressants, to manage this specific burning pain.
But do they work?
But we must be brutally honest about the pathophysiology here. Those medications are just acoustic foam.
Acoustic foam.
They merely alter the neurotransmitters in the brain to muffle the perception of the pain. They do absolutely nothing to stop the glucose from suffocating the nerve in the foot.
They treat the symptom, but ignore the fire burning down the house.
Exactly. The only actual physical treatment to stop the progression of the neuropathy is strict, unrelenting control of the blood glucose levels.
And if they don't get control?
If they don't achieve that control, the sensory neuropathy eventually progresses past the pain stage. The nerve finally dies completely.
And then what?
The burning pain is replaced by a terrifying, total void of sensation, total numbness.
Which initiates one of the most tragic cascading sequences in medicine, the path to non-traumatic lower limb amputation. Walk me through how numbness leads to losing a leg.
It is a devastating chain reaction of pathologies. Because the patient has completely lost protective sensation in their foot, they lose their biological early warning system.
They can't feel anything.
They might step on a thumbtack or develop a severe friction blister from a tight shoe, and they literally cannot feel it. They walk on that open wound all day.
So a mechanical injury goes entirely unnoticed.
Yes, and because of the severe vascular damage we discussed earlier, the blood flow to the foot is drastically compromised.
The liquid sandpaper.
The body cannot deliver the white blood cells or the oxygen required to heal the blister. The wound remains open and vulnerable.
And as we established earlier, bacteria thrive in high-sugar environments.
It is the perfect storm. The open wound is swarmed by bacteria, which feast on the sugary tissues. The infection rapidly takes hold, burrowing deep into the tissue and eventually into the bone.
Oh my God.
Because there is no blood supply to deliver systemic antibiotics, the medication cannot reach the battleground.
The antibiotics just can't get there.
Exactly. The tissue becomes gangrenous and begins to die. At that point, the infection threatens to spread systemically and kill the patient. The only medical intervention left to save their life is the surgical amputation of the infected limb.
All stemming from a microscopic disruption of an insulin receptor. That is sensory neuropathy.
Yes.
But there is a second type, which honestly sounds even more dangerous. Autonomic neuropathy. What happens when the nerve damage moves beyond the feet?
Autonomic neuropathy is when the suffocating nerve damage strikes the autonomic nervous system. These are the deep internal nerves that operate entirely outside of your conscious control.
The background systems.
They run the automatic functions of your body, your heart rate, your digestion, your bladder. When these nerves die, every single body system can malfunction.
What does that look like, practically?
It can paralyze the nerves controlling the stomach, causing a condition called gastroparesis, where food just sits rotting in the gut.
Wow.
It can paralyze the nerves of the bladder, leading to complete urinary retention where a patient literally cannot urinate, or severe incontinence.
It breaks everything.
It destroys the delicate vascular responses required for arousal, making it a leading cause of severe sexual dysfunction. But medically, the single most dangerous consequence of autonomic damage is a lethal condition called hypoglycemia unawareness.
Okay, let me make sure I am connecting these dots correctly, because this is terrifying.
Go ahead.
At the very beginning of this deep dive, you explained that low blood sugar hypoglycemia is an acute, deadly crisis that will kill the brain.
Right.
We talked about the backup generators, the adrenaline, the cortisol. Usually, if your blood sugar drops, your autonomic nervous system panics. You start shaking violently, you sweat profusely, your heart races.
That's a massive alarm.
It's a physical, internal fire alarm screaming at you to eat sugar immediately to save your life.
That is a perfect description. The shaking and sweating are the physical manifestations of that massive adrenaline dump designed to save you.
But with hypoglycemia unawareness, because the autonomic nerves connecting the brain to the adrenal glands have been destroyed by the liquid sandpaper, that alarm bell is completely disconnected.
The wire has been cut.
Oh, wow.
The blood sugar drops to fatal levels. The brain begins to starve. But the autonomic nervous system is physically incapable of triggering the adrenaline response.
So nothing happens.
The body produces zero physical warning signs. No shaking, no sweating, no rapid heartbeat. The patient feels completely normal, perhaps just a tiny bit sleepy, until the exact, sudden moment their brain simply shuts off and they collapse into a seizure or a coma.
That is the most terrifying irony I can imagine.
It really is.
The very condition that is most immediately deadly low blood sugar is now completely masked from the patient's own senses because of the chronic damage from having high blood sugar.
It is an absolute nightmare for a clinician and a constant shadow over the patient's life.
Yeah.
They are flying a plane completely blind.
Just hoping they don't crash.
And this brings us to why modern comprehensive diabetes management is so incredibly aggressive and multifaceted. For a patient suffering from hypoglycemia unawareness, frequent blood sugar monitoring is no longer just a good idea for managing their diet. It is an absolute, second-by-second, non-negotiable lifeline.
This is why the technology has advanced so much, right?
Huge advances.
The classic fingerstick glucose monitors, or those incredible continuous glucose monitors, the little white patches you see adhered to people's arms.
Precisely. We have to outsource the body's warning system to a microchip. The machine has to do the sensing because the biological nerves no longer can.
It's a prosthetic nerve.
Exactly. But management extends far beyond just monitoring the glucose. Because we understand the global vascular destruction, the liquid sandpaper protecting the remaining function of the organs is paramount.
We have to defend what's left.
We have to fiercely, aggressively manage their blood pressure.
Why blood pressure? If the problem is sugar, why are we fighting blood pressure?
Think of the microscopic filters in the kidneys. They are already under immense physical stress, constantly being battered by heavy glucose molecules and osmotic pressure.
Right.
If you add the hydraulic stress of high blood pressure, literally blasting blood through those damaged, fragile filters at high velocity, you will shred the kidneys in half the time.
Just blow them out completely?
So diabetic patients are almost universally prescribed specific vasodilating medications, like ACE inhibitors.
Drugs that physically relax and open up the blood vessel.
Yes, not just to lower the systemic pressure to protect the heart, but specifically to reduce the hydraulic pressure inside the kidney, preserving that delicate filtration system from further mechanical damage.
So we are fighting a two-front war, lowering the sugar and lowering the pressure in the pipe.
Actually, it is a three-front war.
Oh, there's more.
Alongside glucose and blood pressure, we must meticulously control their lipid profile, their cholesterol.
Okay, why cholesterol?
If a patient has low HDL, the good clearing cholesterol, and high LDL, the heavy, sticky, bad cholesterol, that sticky fat, acts as an absolute accelerant to the vascular damage.
How does it accelerate it?
The glucose scrapes the vessel wall, creating a wound, and the LDL cholesterol immediately packs into the wound, rapidly building massive arterial plaques.
It's basically filling the potholes with concrete.
Exactly. You have to aggressively drive down their cholesterol with statin medications to remove the building blocks of the plaques.
So to truly treat the disease, you have to master the glucose with insulin or metformin, you have to shield the kidneys with vasodilators, and you have to starve the plaques with statins. It is an overwhelming physiological balancing act.
It requires immense dedication from the patient and a profound understanding of the interconnected biology from the medical team.
We have gone on an incredible biological journey today.
A deep dive, for sure.
We started by looking at the sheer mechanical brilliance of the healthy human power grid. We visualized the islets of Langerhans, where the beta cells act as the perfect thermostat, releasing insulin to precisely balance our cellular energy against the massive counter-regulatory backup generators.
The baseline of health.
We looked under the hood at how that grid collapses either through the tragic mistaken identity autoimmune assassination of the factory in type 1, or the slow, grinding, inflammatory cellular resistance and pancreatic exhaustion of type 2.
The breakdown.
We broke down the ingenious chemical engineering of drugs like metformin lubricating the locks and the GIP-1 agonists rewiring the brain. And finally, we faced the devastating systemic ripples when the liquid sandpaper of hyperosmotic blood erodes the body's nerves and vessels, leading to amputations and silent, deadly hypoglycemia.
It is a massive, daunting disease that reshapes a patient's entire existence. But as we've seen throughout this deep dive, when you take the time to decode the biological machinery step by step, the disease sheds its mystery.
It makes sense.
It becomes deeply understandable. It is not magic. It is governed by the laws of physics, the pressure of osmosis, and the exact shape of cellular receptors.
Understanding the why and the how underneath the terrifying symptoms changes everything about how you view the condition. It replaces fear with mechanical respect.
It does. And as we conclude this exploration, I want to leave you with a final provocative thought to mull over.
Okay, what is it?
Consider the trajectory of the newest, most revolutionary drugs we discussed, the GLP-1 agonists. For a century, the entire focus of diabetes medicine has been the pancreas and the muscle cell.
Right.
How do we make more insulin, and how do we force the muscle to accept it? But the GLP-1s aren't primarily acting on the pancreas. They are achieving miraculous results by delaying gastric emptying and altering incretin hormones in the digestive tract.
They are fixing a blood sugar problem by paralyzing the stomach and talking to the brain.
Exactly. It suggests a fascinating, massive paradigm shift in endocrinology. It implies that our future understanding of metabolic disorders might not be a conversation restricted to just the pancreas and insulin.
Wow.
It points toward a much more complex, integrated conversation about the entire digestive tract, the vast chemical factory of the gut microbiome, and the profound, instantaneous neurological connection between the gut and the brain.
That's a huge shift.
It raises a massive question for the next decade of research. Could the ultimate future of treating, or perhaps even entirely curing, metabolic disorders lie not in hacking our insulin levels, but in hacking the speed of our digestion and the chemical signals of our gut?
Are we looking at the wrong organ? That is a wild, paradigm-shifting thought to leave on. Hacking the stomach to save the power grid. Thank you so much for joining us on this deep dive. I hope you walk away today viewing your own body's microscopic energy grid and the incredible science dedicated to maintaining it with a newfound sense of mechanical awe.